So like we discussed earlier, it's important to differentiate between small vessel disease and MS. So the corpus callosum is typically involved in multiple sclerosis, specifically the callososeptal interface. Septum meaning the septum pellucidum. So when the corpus callosum is involved, you have to see whether it is towards the septum pellucidum, that is more towards the midline or not. That pattern is rare in SVD. Cortical U fibers, again like we discussed, are quite oftenly involved in MS and they are spared in SVD. Infratentorial involvement is early in MS and late in SVD. This is important. Temporal lobe involvement is quite typical in MS, but temporal lobe is not really involved often in SVD. The white matter lesions are enhancing in MS, whereas they are non-enhancing in SVD. They are asymmetric in MS. And T1 black holes, that is on T1 sequence, dark small round dark lesions are seen in MS. These kind of correspond to axonal loss and irreversible demyelinating lesions, and they are a poor prognostic factor in MS, whereas these are not seen in SVD. Cystic lesions are seen as lacunae in small vessel disease. They're actually what we call lacunar infarcts, but not seen in MS. And spinal cord is frequently involved in MS, whereas they are not really involved in small vessel disease. Okay, so this is important practical table to remember. So we discussed brain tumor versus tumefactive demyelination. Another condition that we must differentiate from MS is EDEM, acute disseminating encephalomyelitis. Right. So in the spinal cord, in EDEM we have a long segment involvement and it is fleeting, and it is usually seen in children post vaccination or in adults post some viral infection. If they are fleeting white matter lesions, they disappear after a couple of months, and they are long segment, that is more than 2 vertebral segments are involved. As far as the brain in EDEM is concerned, there are cortical and juxtacortical lesions, again like in MS, but as far as the basal ganglia, as far as the gray matter is involved, you have the thalamus as well as the basal ganglia that are involved in EDEM, whereas you won't see this in multiple sclerosis. That's how you differentiate. Again, this is a table that helps you differentiate between EDEM and MS. Another condition that was earlier thought to be a part of MS is neuromyelitis optica. Now it is considered to be a separate entity itself, NMOSD, neuromyelitis optica spectrum of disorders. So it is basically because of antibodies against aquaporin 4 channels. These aquaporin 4 channels are present along the ventricles, so you have periventricular lesions in NMO. Again, earlier it was thought that brain is spared in NMO, but now we know that periventricular lesions can be there in this disorder. So in spine, it is again a long segment sort of involvement. More than 2 vertebral segments are involved, and of course you have optic neuritis. So the criteria for NMO is presence of optic neuritis, transverse myelitis over more than 3 segments, and the other diagnoses like sarcoid vasculitis, SLE or Sjogren's should be excluded. Okay, so again this is the right sided optic neuritis that you can see, and brain is normal in this case, whereas here you have these classical periventricular white matter lesions that are seen in NMO. So this chart is the protocol for how to follow up MS patients on MR. Next we come to SACD. So subacute combined degeneration of the spinal cord. I don't have much to say about it except the pattern of involvement. About 60 to 85% of patients with SACD have normal spinal MRs. If the spine is involved, then again it is a inverted V-shaped kind of involvement involving the dorsal cord. Very rarely the anterior cord may also be involved. Okay, so it is the kind of pattern of involvement that helps us clinch the diagnosis. Sometimes the lateral corticospinal tracts and the lateral spinothalamic tracts may also be involved, so you have these small lateral white matter lesions as well. Again, it is a long segment involvement in SACD. So this is chart from Radiopedia that gives a few differentials for SACD. Again, you can go through it and just look at how you can differentiate it from other nutritional diseases, from MS, from infectious causes, from sarcoid and some Sjogren's disease and neoplasms.